for giving me this opportunity. So I'll be talking about management of OSSN in ophthalmic practice dealing with rare. OSSN is a term that includes all kinds of neoplasia of ocular surface, from dysplasia to carcinoma in situ to SCC. It is not very rare in our practice as it is one of the most common non-pigmented tumor of the ocular surface. Clinically, it presents as a fleshy unilateral mass, could be bilateral or multifocal in some cases. And its morphology ranges from gelatinous to leukoplakic to papillomatous or nodular ulceratives. Clinically, we can identify these tumors very easily with the presence of feeder vessels, intrinsic vessels. Rose Bengal stain is very useful in these cases, keratin plaques, and scleral fixity is one of the very important tests which we want to do in each case. So diagnosis, yes, surgical biopsy is one of the gold standard for diagnosing these cases, but we are more intended towards the non-invasive modality like ultra high resolution OCT or UBM to rule out any intraocular extension. Impression cytology, though it's not very confirmatory many times, but yes. And CT scan only in doubtful cases where we suspect any kind of orbital extension. So management in terms of surgery versus topical, we always think of these two when the patient comes. So wide surgical excision with cryotherapy or with or without adjunctive metabolite is a gold standard treatment for these with lower recurrence rate. But if the positive margin is positive, then the recurrence rate is very high. And it may lead to limbal stem cell deficiency, scarring, or any kind of symblepharon formation. Now there is a shift towards the non-invasive treatment, non-interventional treatment like topical therapies, because they treat larger surface at one time and it can be repeatable. It allows higher concentration. We can play with concentration also, and it acts directly over the tumor and it avoids the stem cell deficiency. So when to give these topical therapies, we can use it as a therapy, as a chemo or immunoreduction, as a preventive measurement, and it can be used in any type of cases, dysplasia to SCC, mainly in cases where patient is unfit for the surgery and if the tumor is involving pupillary axis or if the tumor is recurrent or multifocal. So what do we have in topical therapies? There are topical mitomycin C, interferon 2B. Nowadays, people are using interferon 2A and topical 5-FU. Other than that, there are few case reports on anti-VEGF, retinoic acid, topical cytophobic, photodynamic therapy, as well as aloe vera in cases of tumors. So topical interferon alpha 2B is something which is very ocular friendly in these tumors, and it has a very good success rate. And its action is basically anti-proliferative and immunomodulatory effect. But the downside of this drug is it needs refrigeration and it is of high cost and it requires long therapy. So this is a case of SCC proven on impression cytology, and the very good result we found with the interferon alpha 2B. And I have been following up this case for last 10 years and there is no recurrence found. This is another case of pigmented OSSN who responded very well to interferon 2B without any toxicity. Leukoplakic patients OSSN also respond to this therapy, but in this case we have just found a partial response. So we published a case in 2015, a Roger article, where we found that success rate of interferon 2B in OSSN is 91.6%, and they take a longer time to resolve the tumor. That was around 3.5 months. Another therapy is topical mitomycin, which is a very fast drug, and we are all aware of this drug with 90% success rate. Its action is very fast. It resolved the tumor. We got the median time around 1.5 months, but it gives a lot of toxicity to the ocular surface in terms of PED also. So we compared the drug interferon alpha 2B and mitomycin and found the success rate was similar in both the cases, but it was slightly better in MMC. And the difference was in the time of resolution, that was more in interferon. As far as adverse reactions are concerned, then mitomycin in each patient actually complained of something like toxicity or foreign body sensation, and we had to add low dose steroid in each and every case. While in interferon, we didn't get much complaints about toxicity. Topical 5-FU is one of the drug which is fast, with good success rate and cheap also. So this drug also gives a very good response in OSSN cases, in all type of cases except some nodular and nodular ulcerative. So what to assess during topical therapy when we give in OSSN, we have to check the response every time in terms of size, height and vascularization. We have to see whether the tumor has resolved completely or not, or we look at the recurrence. And the most important part is the toxicity monitoring in terms of redness, foreign body sensation, epithelial defect or any kind of follicular reaction. So how I choose treatment in these cases, according to Carol Karp, there is a size of tumor is one of the very important criteria. If the tumor is less than 4 Clark hours, or if the tumor is unifocal or of uncertain diagnosis, they prefer doing surgery. And if the tumor is of more than 4 Clark hours, multifocal or recurrent, they prefer doing topical. But in my practice, I always give equal importance to morphology apart from the size of tumor. If the tumor is flat, gelatinous, or if the tumor is having more of corneal component, I would go for topical therapy first. And if the tumor has nodular ulcerative, irrespective of the size, or if the tumor has tendency of orbital tumor extension, then go for the surgery or chemo reduction if the patient is unable to go for the surgery. Other factors which keep in mind during topical therapy is the ocular surface. If the surface is dry, never start mitomycin C or FU. You can start interferon B. Last slide. And the cost, definitely interferon is very costly drug, and patient may have to spend around 3,500 or 4,000 rupees in a month. Compliance is a very important factor if the patient is on topical therapy, and follow-up is also very important. So in conclusion, there are changing in trends in OSSN management with no touch technique in surgery and non-invasive imaging and topical therapies. But we need to choose the most appropriate treatment regime to minimize the toxicity as well as to improve the success rate. Thank you so much.
Thank you, Rakhi, for speaking on this topic. In just 6 minutes, you covered most of it that I wanted you to. And with that, we conclude this part of the cornea subspecialty. There's one more last part coming up, don't we? And just that because I'll be leaving the mic, so I just wanted to take this opportunity to thank all the speakers, not only in this particular hour, but also in the next part as well as the previous part. I'm sure all of you have done fantastic jobs, just like each of you has done in this session. And I'm sure all of you must have grumbled to start with, what is the 6 minutes? What can we present in 6 minutes? Actually, you can present a lot. You need to present something that I, as an audience or a listener, goes home with 3 messages. Let's say from Rakhi's talk, I know that as a cornea specialist, I need to learn about OSSN. I know that the topical therapy is useful now for these patients, and I know that you have good success. So from each of the talks, if you can leave the audience with 3 messages to take home, that's value. And you don't have to have too many cases. You just have to have maybe 12 slides, but it can be very effective. So thanks for doing that. All of you have been extremely effective. And with that, I'll hand over to my friend, Dr. Anil Radhakrishnan, who's chairing the last session for today. And I thank my patient co-chair and my chair for these sessions, and one more chair who disappeared. And some people couldn't be here, the moderators, they had other commitments. So thank you once again. And with that, I'm leaving this session, but I don't want you to leave this session because this is all put up for by it's like the government, right? By us, for us, and so on and so forth. So it's like that. Thank you very much.